Good morning, West Coast, and good afternoon, East Coast. It looks like we're at the top of the hour, so we'll go ahead and get started. Thank you very much for joining us today for our webinar, Brace for Impact, Mastering the Next Capacity Surge, your ultimate prep guide to scaling high acuity care at home. I'm Jamie Barusha, and I lead marketing here at My Laurel. Before we get started, I wanted to quickly cover a few housekeeping items. First of all, today's session is being recorded, and we will share the recording with all registrants after the webinar. You'll see that everyone is muted to reduce background noise, but we encourage your questions for our panelists. Please use the FAQ function at the bottom of your screen at any time during the discussion. We'll address them in a dedicated question and answer session at the end of the conversation and follow up afterwards if we can't get to everybody live. Lastly, if you experience any technical issues, try refreshing Zoom, and if the problem continues, let us know in the chat and our team will assist. And with that, I'd like to introduce you to our host today, John Branch, Senior Vice President of Growth with My Laurel. John?
Thank you, Jamie. As Jamie mentioned, I'm Senior Vice President of Growth here at My Laurel. Really excited about the opportunity to moderate this panel with these senior clinical executives that are spanning large health systems from the East, Central to the West Coast. On the screen here, you can see what we'll be doing for the next hour or so as we guide through the session. So we'll start with some brief introductions of the panelists, let them explain who they are, their role, the organization they represent, and some of the work that they're doing now. We'll then pivot to the panel discussion. So we've got some prepared questions for the panelists to answer. We'll let them elaborate and certainly talk amongst each other, strategies, tactics that they're using. And then that should carry us to the Q&A session. As Jamie mentioned, please continue to put your questions in the chat as we go along. We'll do our best to get to them. We anticipate there'll probably be a decent amount. If we don't get to them, as Jamie mentioned, we'll have some sort of response prepared with the recording as we send out. So with that, I'll go ahead and get started and introduce our panel. If you go to the next slide. So I'll do a brief introduction of each of the three here, and then I'll ask each one to go into a little bit of detail about themselves, their organization. So first, we'll start with Dr. Chris Dale. He's coming to us from Providence Health. He up there in the Northwest. He leads strategy and clinical innovation across the enterprise as the medical director. We then have Dr. Logan Davies, representing the central south part of the country from Ochsner Health. He leads, he's the medical director of access and throughput across the enterprise. And then lastly, we have Dr. Matt Wiseman, who comes to us from the East Coast up there in New York City, Brooklyn area, representing Maimonides Health as the chair of medicine. And so before I ask Chris to jump in and describe Providence and himself, there's a couple of reasons why I'm really excited about this. One, you can see the diversity of perspectives and the local challenges that each will have, and they'll be able to weigh in on that. But also, after getting to know these individuals, they're extremely intelligent on these models, care models in the home, not just from the clinical perspective, but the operational and the economics. So I really look forward to their perspectives as we kind of dig in, and they represent the whole holistic picture of their organizations and what they're dealing with. So with that, I'll hand it off to you, Dr. Dale. If you could just maybe describe yourself, your organization, some of the things you're working on, that'd be great. Thank you.
Sure. Thanks, John. I appreciate it. Yeah, it's good to be with you. I'm coming from Seattle. I'm part of Providence. Providence is a pretty big organization. You see it on the map there, I guess, with the majority of states in the Western United States that we serve. We have 51 hospitals and really kind of a whole variety of different care environments. The West tends to be, pretty rural. And so some of our hospitals are in big cities like, Seattle or Portland or LA. But some of our hospitals are in small towns like, Kodiak Island or, up in Polson, Montana. They're just like, pretty small places. And so that's really kind of a fun part of being part of Prov is that we're a pretty mission-focused organization, been around like 150 years. And we're really focused, like our vision is on health for a better world. And it's a hard time in healthcare, and my little corner of the organization called Virtual Care and Digital Health is responsible for trying to figure out ways to leverage services across the enterprise to really help us live our mission. And this part is a giant part of it. I think the next slide has some more details on Prov, but honestly, I kind of forget. Oh yeah, this is more about us. So yeah, virtual care digital health, we do a bunch of different things. Like I'm the medical director of clinical innovation, and so I do some AI implementation work, some telecritical care work, and then this work for us, hospital at home, is one of the kind of the uh, system programs that we operate across the geography. And so we're talking about how we've come to be where we are today, and then some of our thoughts about where we're going from here, just in terms of meeting our mission, and then also really trying to improve the environment in which patients get care, and then the value of care that we're delivering. So just super happy to be with you all and part of the panel.
Thanks, Dr. Dale. I think Dr. Davies, you're next.
Hey there, everybody. I am Logan Davies. I am here in New Orleans, where I work as the hospital medical director for access and throughput of the flagship facility for Ochsner Health, which is our preeminent and kind of large superpower, if you will, health system on the Gulf Coast. Our facility that is here in New Orleans, where I'm based out of, is among the most, if not the most, specialized healthcare facility on the Gulf Coast outside of all the medical centers in Texas. We have about 50 hospitals in our portfolio, around 400 clinics and urgent care settings as well. 40,000 team members, and 5,000 of those being physicians. So we have a very robust workforce that's very engaged. We do about 3.5 million in terms of patient access, creating opportunities a year for us. Let's go ahead to the next slide. There we go. And I think one thing I would impress upon the audience, just like my co-panelist here, one thing that is in the DNA of our organization, we might have scale and breadth and a lot of power with our workforce. But we're also very much committed to innovation. And we see that as the way forward in operations quality, how we achieve things across our populations of patients, but also how we set new standards in healthcare. Ochsner, where we operate, is amongst the highest, if not the highest, in terms of the vulnerability index by Vizient standards, if you are familiar with Vizient. Um, because of that, we have to innovate not only to be an effective clinical enterprise, but also to help our patients survive. And so that's the reason that we came to this exercise. Certainly, we wanted to achieve efficiency, and we wanted to do better in terms of our operations, but we wanted to do better for our patients as well. And so I know that I'm excited, and my co-panelists are excited to talk a little bit more about the model and how that extends the reach of our enterprise, as I know that it's doing with theirs too. So good to be here.
Thanks, Dr. Davies. Dr. Wiseman?
Thanks, John. It is a delight to be here and to learn from my esteemed co-panelists. I'm Dr. Matthew Weissman. I'm a primary care med-peds by training. I'm the chair of medicine at Maimonides Medical Center in Brooklyn, New York. That puts me in charge of the quality of care and the research and the education that we deliver here. And, it's unusual for me to be sort of the small fish in the big pond coming from New York City. But I do feel that way today. I mean, here we are, independent, sort of New York's only independent 711-bed hospital that was really founded back in the early 1900s to serve the community. And in some ways, we're still that. We're still very much serving our local Brooklyn community. On the other hand, we're a bustling academic medical center with the highest levels of tertiary and quaternary care in the Brooklyn, which would be the fourth largest city in the country with a population of around 2.65 million, around 500,000 or 600,000 children, which is more than the total population of Boston. And so we are Brooklyn's only children's hospital, one of the few adult trauma centers, and the only pediatric trauma center. And we're providing all this advanced care throughout Brooklyn. and serving as a referral center and also as a safety net hospital. And so we have a high proportion of governmental insurance. And so, as Logan said, we're trying to figure out how to innovate, how to take care in a very busy urban center of our patients in the most health advanced, but also health throughput advanced way. And that's why we're here today, is to share what we've been doing and to learn from others about how to do that even better.
Thank you for that. Really excited about getting into this, but yeah, I may take just a minute here for those that are joining that may not have as much familiarity with My Laurel. Speaking of the small fish in the big pond. So we're a mobile medical group. We provide acute and transitional care in the home for the most complex patients. The way we do that is we put skilled clinicians in the home paired with virtual physicians and nurses. When we go into the home, we provide the full complement of tools, technology, diagnostics, supplies, and a formulary. Built within the ethos of the company firmly is we need to be accountable for the outcomes that we deliver, or else we shouldn't be paid. And so we've put our business model at risk for just that. And we partner with organizations like hospitals, health plans, ACOs, PACE programs, and the like. From a group perspective, we have clinical resources that we put within the four walls of the hospital. We also have field responders in the form of specially trained paramedics or APPs in the home. And again, they're paired with virtual physicians and nurses. For our part in this conversation, in terms of capacity, we fundamentally exist to prevent unnecessary hospitalizations. And we can do that and attack that problem on the front end. We can do it on the back end. And so we look at the visual below. It's really around, from left to right, identifying those high risk, highly complex patients that we know 30% of the time they hit the ED, they're going to get admitted to OBS or inpatient. We want to get to them in the home, and we want to take care of them there, stabilize them, and then for a period of a week or so following, make sure that they don't end up using the ER and transition and graduate them to primary care where they longitudinally are managed. If we go further downstream, patients that do arrive into the hospital, they make it into the ED, they get MTELIS screened, triaged. But now we look at, do they really need to be in observation? Do they need to be an inpatient? Or if there's a safe, effective alternative at the home where we can treat them the same day, and then for the next 2 weeks to 30 days, could we actually keep them out of the hospital and prevent them from coming back by using both in-home and virtual care? As you continue to go downstream, patients now that make it to the floors and have an inpatient stay, identifying a day and a half, 2 days early, can we safely and effectively get them to the home, take care of them there, both in person and virtually for the next 2 weeks to 30 days, preventing them from coming back into the hospital. And lastly, in the most downstream, patients that make it through a full length of stay inside the hospital setting, but have such high social risk factors, history of past, repeat utilization. Can we follow them home that same day within 24 hours and take care of them for the next 30 days to prevent them from coming back? And so when our partners, hospitals in particular, kind of combined all of those or parts of it, we're really trying to address that capacity throughput challenge, the risk associated with readmissions, reutilization, and then those heavily leaning into value-based care obviously can prevent those unnecessary hospitalizations. So that's a little bit about My Laurel, but to transition now to the main part of this session, we'll get into the panel questions now. And so for the first question, I think I'll start with you, Dr. Davies, coming out of Ochsner, describing some of the challenges and the vulnerability of your population. Care to share a little bit more about where you are in the journey and care into the home?
Yeah, certainly. So, Ochsner started this journey about moving care into the home with earnestness probably almost even a decade ago. We were one of the early adopters of the ramp of wavered based hospital at home, and I know that there's a lot of forefathers in that space who go back even further than a decade. But when we were seeing all that activity in the mid 2010s, Ochsner was right there in it. And through that approach, we could not find a sustainable footing for a lot of reasons. The regulations, the cumbersomeness of the model for our operational ethos, for the overhead that was required. We just could not get a return on investment. So we stood down from that model in the mid 2010s. We did have some services that were providing some in-home primary care, ambulatory access creation in the period around COVID. And we come out of the COVID timeframe where probably like many organizations and provider entities, we started to see our care being consolidated, especially into our urban areas and our high acuity health centers for a lot of different reasons, workforce being a principal driver there. And as we came out of COVID, what we're figuring out is that we could not stay on top of our needs to generate capacity. And we have worked very earnestly and actually made a lot of improvements. I think if you were to look at us in a lot of the databases where we're compared to one another, you'll see that Ochsner, in particularly this facility, performed very well. But we certainly, want to aspire to be more efficient and continue to work on that. But there is a certain ceiling. And so entered into the conversation is that we need to figure out a way to safely, capably, efficiently extend the four walls of our institution. And we knew that the road was not through the path that we had gone in the past. So we endeavored to do something different, to do what our organization is known to do, and that's to innovate. What is a little bit of a new stance for us is we have a lot of organizational pride. I think probably like many of you all here, you look at your workforce, you look at your resources, and you believe that you can do, and there's a track record of making things happen. And we have that too. But what we also came to a reckoning is that we alone did not have the institutional memory to really support our vision of what we needed to do in this space. So we were really looking for a partner who could help us to craft a at-home care solution as an extension of the Ochsner brand, but also bring to it as the partnership a lot of intelligence, a lot of know-how, a lot of expertise that we would be catching up if we were to reboot it from the ground floor ourselves. So about 2 years ago, now we were, I think it's safe to say, the first dance partner of My Laurel as the entity that they have come to be, and co-developed acute care at home. We are now probably just shy of around 2,000 patients being enrolled in our suite of services. We do two different approaches. We do ED and observation avoidance, so it's a purposeful decantation of low acuity admissions from the hospital's front door. And we also do another approach where we focus on high risk for readmissions patients and keeping those patients out. Through this partnership, through this collaboration, through this shared mindset and vision, we have achieved some really great things. We'll go into a lot of those in greater detail in a bit, but just to kind of give you that, top line of what we've done. These patients, many of them who are earmarked for these services, they are known for their recidivism, their revisit tendencies. And so through this model, we've been able to move an incidence of revisits down from something like 30% incidence into, in some instances, down to the single digits in terms of revisit percentages. So that not only is great for us from a facility. I talked about we needed to create capacity. We're doing that. Certainly, there is the financial aspect of it that we can share some details on a little bit later. It's really about value generation that is unlocking it on several different levels, including to our payers who were engaging with this model. But most importantly, it's about taking care of those patients in a way that is closer to them and on their terms. And so by moving care into the home, I think that we've been able to achieve that synergy of all the value. So we've achieved a lot. There's a lot more to come, but that's our journey so far.
Thank you, Dr. Davies. And I think what you did was a tease there for later on some of the questions that are coming around outcomes. But Dr. Dale, if you would be so kind to maybe share your response where you are at as an organization today.
Yeah, sure, totally. And just to confirm, you can hear me okay?
I can.
Oh, sweet. My
Sounds
computer
great.
decided it hated Zoom, so I had to switch to my phone. It's reinstalling Zoom, and it's going to take a long time, evidently. Big file.
Well, you're in the
So,
Windows area of the country.
hey, there
So
you go.
anyway,
That's quite true. Yeah. So our care journey, like where are we in our journey to bring care to them? That's an interesting question because to reflect on that, actually, I go back to something I said at the beginning, which is Providence as an organization is quite old, like 150 years old, and we're on corporately on this journey from being kind of this internally we sometimes call it about like a journey from being a holding company to an operating company, meaning that the origin story of Providence is the Sisters of Providence kind of went up and down the West Coast and founded hospitals, and we're really focused on being in the community and meeting the needs of the community. Like that's uh, part of our founding story, which is very much alive and well in the organization. And so I think the organization from the beginning was in the community and was active and was meeting people where they were. And I think that's where we start. Maybe that's like Epic One or whatever. And then the second thing I just say is like, oh, we went through this long phase of time where we really operated hospitals. We're very hospital focused. And maybe there's some spinoffs kind of related to that with home health and with we had a visiting nurses service for a while, but Providence kind of grew a bit by acquisition and reacquiring things that were founded, but then kind of left and then came back and all this stuff. And so, if you fast forward to about a decade ago, at that point in time, we were looking to do more value based care, at least here in the Pacific Northwest, where there's relatively low penetration of it. We tried to start up hospital at home at that point in time with a couple of like very significant risk based contracts that we have, as well as our own employees, and really weren't able to make a successful go of it. It just, as people have been in this space for a while, and I see they're, 45 or whatever, there are people on the webinar. Like it's hard. It's really hard. And just like today, I was teasing John earlier is, like all this stuff going on in Washington today about the waivered hospital at home program and the continuing resolution, the government shutdown. Like we operate a waivered program now. And I'd say this is, we're in the second wave of our second epic of our organization where now we have a waivered program. It's one of our hospitals. It's a great program, but it's relatively small. Like I mentioned before, we operate 51 hospitals and we're only live at one of them. So that's just probably not enough. Like we got to grow, but we have limitations. And if anybody's joining from the state of California, that the California Department of Public Health doesn't recognize their right to, or they don't feel that they have the right to regulate waivered hospital at home programs. So you can't operate a waivered hospital at home program in the state of California, which for us with significant operations in Northern and Southern California is just really tough. And then other things like we have, a number of collective bargaining agreements, and they sometimes stipulate that no work can be kind of subcontracted. And we had different parts of the organization doing our in-home work, and it just became quite difficult. Tough sledding to operate this waivered program that we have right now. And so I think we're at the end of our the second epic of our journey. And then the third one, I don't really know. I think that's what we're starting right now, which is, we're looking at companies like My Laurel and asking the question, is a waiver the best way to operate a program? And, we're at the point now where we're kind of running, one of our leaders called it a contest of ideas, where, he said, hey, like, let's just see which is the best way in terms of, Logan, what you were saying in terms of care for the patient. Like our program that we have right now, we are super proud of it. Like we measure something called the Net Promoter Score, which is one of these kind of, patient experience, customer satisfaction sort of things, where you add up your good stuff and you subtract your bad. And our Net Promoter Score for our programs, 88, which is just like, it's crazy. Like it's, higher than Starbucks and Dunkin' Donuts combined or something, I don't know, but it's like, it's a really good score. And patients love it. Like if you operate one of these things, that like, it's super easy. Like we had last month, a grateful patient did an anonymous donation of $10,000 to help continue to fund the hospital at home program, just because they were so enamored with the care that they received. And we get these stories, on a daily, weekly basis or whatever. It's just people really like the program. Like it's really, really missional. It's awesome work. And it's super tough sledding. So, maybe we can kind of get into that a little bit more, but I'd say that we're very incomplete in our journey because I think we started really being very much rooted in our communities and serving people where they were, serving patients where they were or where they existed. I think maybe we got away from that with all the technology in medicine and everything.
And we're in a hard place right now. And I think what we're looking for is some way to bring humanity back and bring care back to the people who need it most in their homes and who love it when they get it there. So, I think the journey is, we're on it.
It's great. Thank you for that, Dr. Dale. Dr. Wiseman.
Thanks. So, I think we're pretty early in our journey for home care. I think, like many people, we started with things like video visits a few years ago. We have had a geriatrics program with home visit, nurse practitioners going to the home doing primary care visits. It's been very successful for years in terms of reducing ER visits and hospitalizations, but it's relatively small compared to the population that we serve. About 9 years or so ago, New York State had a Medicaid waiver, and a big piece of that was to create community partnerships. And that's really enabled us not to have to build a lot of the things that we're talking about today, but to enter in partnerships with community programs. And so we've done a lot of that with organizations like JASA, which does home care, especially for elderly New Yorkers. Around the same time, New York State also built a Medicaid-driven health homes care management program. Maimonides happens to run the largest one of those. And so it's another way. It's part of us, but it's not part of us. And we, helps create this connection to patients in their homes. But, still that's different than I think the gist of what we're talking about today. We haven't really dived yet into a hospital at home program. We did partner with My Laurel a couple of months ago. We're at the beginning of both the readmission reduction program and the reducing length of stay programs, and happy to talk about that a little bit. It's a natural fit for a lot of the stuff we've done, as I described, a lot of the partnerships around care in the home. We also run, I think, the largest ambulance fleet in New York City after the fire department, and we partner with a number of community volunteer operated ambulance fleets. And so there is this sense that we should be where people are, that we should be in their homes and connecting to them. And, now the strategy is like, how do we find the right way to be in the right homes at the right time?
Great context setting from everybody. And Dr. Wiseman, I think I'll stick with you for the next question, which is, and you started getting to it, operating the largest health home, the vulnerable population that you're serving. There's quite a few challenges, capacity-wise, readmissions, et cetera. What are the challenges specifically that you're looking to solve for as you're architecting this strategy going forward?
Right. I mean, I think it's a lot of the same things that everybody on this call is dealing with. I mean, we have a busy hospital, and we can't take care of all the patients that we want to take care of. We have backups in the emergency room. We have throughput issues on the floor. Our patients are exceedingly old and sick. We often say that we take care of the oldest Brooklynites and their parents. And it's true. We have a very old and sick population. And so finding ways to take care of them in the right setting to reduce our length of stay and admission rates, to be able to improve the throughput to the point where we can take care of the new patients who are coming into the emergency room in a safe, efficient way. And, making sure that people are connected in their communities back to primary care, either our primary care or the community primary care doctors. And, they can get as much care as possible out there instead of having to come in here.
That's a great point. Dr. Davies, I'll go to you. Maybe a unique take on this is, again, you're in the hospital setting, the health system, thinking about access throughput in between the four walls. But I think through the program, through the experiences you've had, you've also not only focused on how to get the right access to care inside the four walls, but how do you start thinking about value-based care and all the other initiatives Ochsner's putting into place? Maybe talk a little bit about some of the challenges you're solving for at Ochsner.
Yeah, certainly to echo what Matt just said is, Primary driver was we got to free up space in our busy hospitals. But as you've alluded to, a lot more came into focus as we actually did the work. Um, Ochsner, as an organization, we do really great care in traditional brick and mortar locations, and even with some extension in ambulatory virtual programs. But what this exercise has shown us and put a microscope on is that we have a bit of a organizational blind spot. And I mentioned kind of institutional memory deficits. You know, one area that we haven't really um, perform to our performance standard is in transitions of care. And when we brought this resource in to help us with generating capacity out the front door, you know, we did have in mind as a secondary kind of measure was when patients come back, what's going to be the impact of that? And that soon became a primary measure of our success because what we got in return was that these patients were performing so much better than the status quo that we had admittedly just come to accept that like you get all their care done efficiently and as well as possible in the hospital, um, complete as possible, quickly as possible, and then you just watch it go to dust. And I can tell you, I sit in a lot of seats, but at the end of the day, I am a physician, I am a provider, and to be really frank, I was tired of that exercise of just being on the hamster wheel running fast and not seeing all the good work pan out as to what comes next. And so, what was really illuminating and eye-opening, and actually um, builds a lot of trust and momentum in that, you know, positive sense is to see how we could better transition patients' care. And it's not just about like keeping them away, it's keeping them better. And as Chris mentioned, like this value proposition it hits on so many different levels. You certainly will solve your aim of opening up beds. You will certainly, as I told you, you will land the plane of complete care better every time. And then, and I think most importantly, is that people will see. So that net promoter score that Chris talks about, we monitor that with our patients. This is a home run. We perform in the high 90s in terms of our net promoter score for this program. You know, health industry averages are like in the 40s, which I think it's a sobering stat to hear, but is it really that surprising? So again, where you meet patients where they're at, you can achieve all these things on their terms, and you know it's also good for us too. Another part of that, and I encourage people to think through this, is your provider teams, your discharge planners, your clinic-based assets are customers too. Um, they need to build trust. They need to build a positive sense of rapport into our systems and our process. And we're also seeing that we gauge that voice of the customer, and similarly, we perform almost as well as we do with our patients in terms of their value of this program. You know, the other thing, John, I would mention, you mentioned value-based care. And I think a lot of times people think about that as like a financial arrangement, you know, these agreements of risk sharing or capitation with insurers. And that certainly is true. We have a lot of skin in the game through that model, and this has proven to be a value add there and then some. But value-based care is more than just these financial models. It gets back to what I'm talking about is really doing the best care most completely nearest our patients on their terms and to their satisfaction. And I would say as a second kind of fiddle to that, but a near second is also to the satisfaction of the teams of providers who take care of them. You know, we're tired. And this is not going to get easier. And I think it is incumbent of all of us as health leaders to say, okay, certainly we're going to do what we're going to do to make care better and more efficient, but we have to do care differently. And I think that that is what this exercise is all about. And you know, for me, it's really given me a renewed lease and hope. for what we can do in healthcare in admittedly really trying times.
Appreciate that, Dr. Davies. Dr. Dale, how do you think about the challenges you're looking to solve for?
Yeah, I like actually looking at what you said about that it's like discharge isn't really the victory, that people getting better is the victory. Like that's the thing you're going for. Because I like the humanness of that, and I also like the fact you kind of called out that you think about length of stay, and that's something that all of our organizations are probably grappling with, and like trying to figure out a way to improve. That if you're a doc and you're taking care of someone, and you're like, "Ooh, I don't know how they're going to fly at home," you're probably going to hold on to them another day, another 2 days, or whatever, to tune them up a little bit more. Like have them, finish the IV antibiotics that maybe they could have got done in another place, or diurese a little bit more, or another day of IV steroids or whatever it is, just to make sure that they're going to do okay. I think a lot of our physician and APP colleagues feel like caught between the pressures of doing right by the patient, but then the organization saying, "Hey, you got to improve throughput. Like, what's your discharge by 11 time?" Or whatever the metrics are that people are held to. And that, I don't know if it's moral distress might be too strong a word for what it is most of the time, but just those paper cuts, they wear on you. And so I appreciate the fact that you called out that people get tired of it. And I think that's kind of where people are. Is I kind of put the things that we're trying to solve into three buckets. The first one is we're trying to do right by the patients, and we have a saying about hospital at home is that it's not right for everyone, but for the people that it's right for, it's really right for. And what I mean by that is that as we approach people, it's only about 60% that say yes. So medically, they're like every place probably's got their own kind of rhythm of screening and things like that. Like how do you get people into the program? But for us, once you start approaching people, you kind of explain what it looks like to go home and to get advanced care at home. And not everyone says yes. Like, a chunk of people, they don't want other people coming into their home, or they feel more comfortable or safer, maybe even in the hospital. So they want to stay. Some people is the opposite, is like, "Oh no, get me out of here. Like I want to get care at home." And so, um, you know, an advanced care home program isn't going to serve like 100% of patients ever. Like we target like 3 to 5%, something on that order of our inpatient discharges is kind of like, oh, we think that that's a very achievable, conservative sort of percentage of the people for whom the program is right. But we want to do right by our patients. That's the first thing. And then the second is about throughput and about just helping the hospital operate better. Lumped into there are margin pressures, and it is just healthcare has been pretty tough for a long period of time, and things are really tough right now. And we need ways to improve the efficiency of DRG-based care production, improve the value of care that we're able to deliver. All these kind of like financial operational pressures. Hospitals, like it's expensive. I hear $5 million to build a bed. We're chronically overcrowded with boarding the ED, which is terrible from a patient care and flow perspective. Like yada yada yada. Like all these financial operational challenges, which if you can safely decant people in a way that is economically sustainable, like particularly getting back to point number one about if patients like it. I did also notice that Logan threw down the gauntlet of his net promoter score is greater than our net promoter score. So we're gonna have to like figure out that. We're gonna have to net promoter score off or something like that. But yeah, but if you can solve for some of your operational challenges in a way that is done right by the patients, like Bob's your uncle every day of the week. And then the third thing, is doing right by the team and making a care environment. And the nurses and the pharmacists and the folks who work in our program, they love doing the work. Like it's very, it's saying it again, but it's very missional work. Like there's nothing more sacred or important or impactful than being in somebody's home and seeing their real life. Like it flips the script. Like it takes all the power dynamic out of the hands of the physician or the nurse and puts it in the hands of the patient and their family, in terms of you're a guest in their home and you're the one who's like gonna engage in their environment and try and really understand. People make a lot about talk a lot appropriately so about social determinants of health and those things, but you see it firsthand. You see like, oh, the jumble of medicines, oh, the fact that the oxygen concentrator doesn't work, oh, the fact that like the transportation really doesn't exist, all these things that you can kind of solve for if you know about them, that they're there and they're in front of you. And that is just, that's incredibly awesome for the members of this team. And then just for the greater, I said at the beginning, but for members of the care team that really are kind of like feeling squeezed by the pressures from, maybe administration to discharge people more frequently and quicker and all that stuff, like this is a way to ensure that people get the care that they need in a way that like makes everybody happy involved. And I think that's just great in terms of, fighting burnout and stuff like that. So, I think probably different organizations are solving different challenges, but I think there are several that, we think that this addresses.
Right. And can I add to that, John?
Please do. Please do.
I mean, I think you said this, but the reassurance for our hospitalists who know that patients have, it's great for the patients, but the reassurance for the hospitalists that patients have a safe landing spot when they're going home a day or two before they otherwise would have gone home. It's bringing them a sense of joy that I think, to Logan's point, like people don't feel a lot of joy all the time, and this gives them joy, reassurance, comfort as they transition those patients out.
Yeah, exactly. Like I'm on the inpatient medicine side. So like Logan, I see like a discharge as like a victory. Like, oh, we discharged the patient. Awesome. Like game over. Let's go home. And Matt, you're on the ambulatory side, right? So it's like, you see that as like the start is like, okay, they're out. Okay, what do I do now? And that's like, that time is so vulnerable. And if you look at the data, like the readmission rate, which that's a very crude thing, but the care probably too, is lower. The care is better. And people who have a safer landing zone. So yeah, I appreciate you calling that out because I think it's totally an important thing.
Yeah, I mean, I'm not to digress too much, but maybe as we get into challenges a little bit, Chris, I'm sort of curious, one of our challenges is as the inpatient folks discharge people, there's another one, there's another person coming right behind them. And so it's like a victory to discharge somebody, but also a challenge that now you got to start all over again with somebody else.
Yeah, I get that. Particularly if there are 2.5 million Brooklynites waiting in the lobby.
Right. They're all in the emergency room right now.
Yes.
Well, I think one of the places we'll go next, and just keeping track of time, we've got about 20 minutes or so, and then we'll take some time for some questions as they're coming in through the chat. Dr. Day, I'll stick with you just as we're kind of going through this. You were starting to hint on it, but there's various levels. And again, you're sitting in the Providence enterprise where you've got multiple regions, and then at the region level, you've got hospitals. Then at the hospitals, you've got leaders, you've got clinicians, and then you've got patients. How are you tying all that together to create that buy-in? You started talking about it here.
Yeah, 100%. I mean, and I think I like those buckets. Like I think of it as three buckets. Is one, you have your kind of leader bucket, and that goes from the level of like the CMO, CNO, COO, or chief exec, whatever the administrative head of your hospital is called, up to like leaders above them who are responsible for regions or divisions or whatever the org structure is, and maybe even people who are responsible for service lines as well. But their thing is they want to run good programs that take good care of people, and they want things to work, and they want the numbers to line up at the end of the month or quarter or whatever. And I think at a high level, like I'm generalizing a little bit too much there, but they're in it for good reason. Like they're in it for kind of like patient-centered and missional reasons. It's just like things need to operate well. So the program needs to I always think like under promise over deliver. Like you got to say what you're going to do and then go out and do that thing and more. And like it's incumbent upon us who run things to make sure that we solve the problems of every day, like people showing up to work and people doing the right thing and people following workflows and like how do you design those systems. So I think that's kind of like that's the management piece of it, is like running programs that are successful and work well. Clinicians, that's a very interesting one, and really like I think it's kind of fun is selling to doctors in terms of a new service line is kind of like a new offering is an interesting thing, because doctors are very, I mean, this will shock no one on the call, opinionated about things. And, they like, you don't enter into the profession and you don't exercise your judgment repeatedly day in and day out on behalf of your patients in this like fiduciary manner if you don't kind of like trust your own instincts and judgments about things, and have like, you need some level of autonomy in that in order to be good at your job. And so it's not you can't beat people over the head with stuff. You have to be gentle and show, and it takes time. And, just our experiences, we're 4 years into operating our program, is, I think we really kind of hit our stride maybe 3 years in or 2 years in, where it just took a number of discharges. We're on our, 700th or 800th patient now. And, people now know and trust the program. They call us, they it's just, a victory is hard won. And trust, you got to develop trust, and it just takes time. Like, I don't know other than being transparent and bringing some crumble cookies on occasion. If they're better cookies in Brooklyn or better beignets or wherever they are in New Orleans, we probably should adopt those. Maybe that would improve our rate of change. There's probably some things we can do there gastronomically to improve our change management. But maybe both suggestions. But the clinician piece is like, it's fun and it's like that's really good work and it's necessary work and it's hard work. And the last one is just patience. Is like it's a little bit tricky with advanced care at home or hospital at home is because patients are very vulnerable in the hospital, and like 9.5 times out of 10 or 8.5 times out of 10, like they don't know the first thing about when you go into somebody's room to talk about the program. They don't know the first thing about like this thing that you're going to tell them about. And so we had to really think through and script that interaction in terms of, oh, well, here's a brochure that explains it and is kind of the FAQs for patients. It has a QR code so that if they want to pull up a video on their phone, and sometimes it takes like one or two conversations to like explain what the thing is, because we're not trying to coerce people. Like our goal is to help people make the right decisions for them, but we really feel like we believe in this as like if you want to call it a product. We believe in the product. Like we believe in the fact that you're going to get really good care. You're going to have really good outcomes because we can show you the data. Like it's a good service. But we also recognize like people need to do what's right for them, and so being able to like believe in it and kind of stand behind it and be able to explain it, like that's kind of the North Star is the patient. So it's kind of like the order there, the management, clinicians, patients is kind of like that's the upside down pyramid where we're all trying to do things right by the patient. The way management does that is to create good operating environments for the teams and the clinicians and stuff, and then management, like we're there to help kind of like support them to create a good program that then creates good care for patients. So I don't know, that's kind of how I think through it, like logically or whatever, but we've won some and we lost some, and it's always a work in progress.
So that sounds great. So I heard systems of thinking and food is kind of
Food, yeah,
the
it's bottom line.
strategy.
It's just food. It's bottom line.
Got it. So in the spirit of time, Dr. Davies, I would love for you to maybe address this question and the next question, which is the outcomes. So we'll flash this question and maybe the next one. I think,
Yeah.
Dr. Davies, I know you've got some experience with building consensus and buy-in across programs at the ground level, at the executive level, and every level in between. And then Jamie, if you don't mind moving forward to the next slide, talks about a little bit about the outcomes. Maybe if you can weave that into your response as well, that'd be great.
I can do that. And I'm just being mindful of the audience. I'm sure there's a good number of providers out there, clinical leaders. I know we're being very heavy-handed with the human aspect of this, and that is the most important thing to underscore about this program. But also, I mean, maybe a slash of realism or cynicism. It's just how we have to operate. It gets to the root of these questions. You're probably wondering, well, this sounds great. How do you convince people, especially the people who manage the purse, to invest in this type of stuff? So welcome to my life for the past few years. My first bit of advice is, Chris alluded to this. As scientists, which clinicians are, and by proxy, I think our members of our team, including our administrators, we're all scientists. And so the scientific method is rooted in you have a question, you make a hypothesis, and then you have to actually do something. And certainly there's some diligence and preparation in preparing for the actual intervention. But I would tell you, you just got to do it. That's one of the biggest things. You got to show people what is possible. Don't get stuck in that analysis paralysis. It doesn't mean go into things foolhardy. Do your diligence, but don't get stuck in endless analysis. You're going to win fast or you're going to fail fast. So I would tell people, get out there and do it. And that's also important because you got to produce enough scale to be able to actually measure your impact in a meaningful way. So you've heard that, like, okay, yes, we were able to move the needle in patients being high risk for revisits from like 30% down to single digits. That's what we were able to show over hundreds, thousands or so cases. But in the meantime, we're also demonstrating that value proposition case by case within members of our group practice, our discharge planners. We're building that trust. And so there's an element of feedback that is constant in there until people see it, they believe it, and then they start to kind of self-propagate it. The other side of it, And again, coming back down to just like this is what we are. We are a business. You got to show ROI. I would tell you, you've got to have certainly engage your finance leaders from the get-go. They need to be on the ground floor of this. They need to be in the nucleus, whether it is this model or a traditional hospital at home model. They need to be steering this from the ground level. They do not need to be caught up after the fact, because if you don't catch them early, you're going to spend a lot of time catching them up if you catch them up. So you've got to have them there. You've got to work with them, understand what your kind of revenue opportunities are. These services cost something. And so you got to understand your cost basis. You got to understand when you free up that bed, what's your patient mix look like? What revenue is going to come back into that bed? I had to lean heavily on my finance people, and they were telling me, well, we've not done this exercise before. And I said, we're going to figure it out. And that's the other thing, is that I think as a clinician, I have to make, measured, assessments and calculated risk all the time, empiric treatments. That's not so normal for a lot of people who are on the other side. So a part of that is also building trust with them, giving them the audacity to leap, telling them to kind of navigate into the great wide yonder, and then figuring out those measurables together and bringing it back to them. But you can show them what the outcomes are and the ROI and all those things. Just to kind of speak to those bullets instead of just being vague. I've talked about our revisit numbers. We were able to reduce that by in excess of 50% of absolute risk reduction, relative risk reduction on those things. Our revisit is well over 60%. We've been able to generate over 7,000 bed days of care, something like 900 new admissions by the current footprint of this program. 7.5 beds a day are being generated at this facility alone through our ED and observation avoidance programs and our readmission reduction, and we're just getting started. Moreover, where we're at right now, we sponsor the fee basis of this because really we are an extended pilot. Yes, we may be nearly 2,000 deep, but we are still figuring this out. But even with that fee basis, we generate almost a 9x return on investment by bringing in patients who need to be in the hospital with higher acuity conditions and also margin producing care. So it gets back into that adage that we all hear about the right patient, the right time, the right place. This is mutually beneficial across kind of all the different camps, our providers, our patients, and our organizations, including our bottom line. The other last thing that I will say, it gets lost in all of this, is workforce. Um, I don't know about who else on this call is in a population losing area, but I have to be mindful all the time that I don't have providers, I don't have nurses, you just go down the line. The other thing that I need to be smart about and do different is to leverage good partners who can also network amongst a nationwide of workforce applicants and whatever they have on their roles, that doesn't have me trying to rob Peter to pay Paul. We build a lot of good programs here, but a lot of times we end up cannibalizing one to support the other. So that's another consideration in this that was a value add to the proposition, in addition to these outcomes, the patient satisfaction, the ROI. But biggest takeaways I would tell you is got to be audacious. You got to try, win quick, fail quick, and you got to have your admin finance people on side of this at the ground floor. If I were to give you two pearls of success from my vantage point.
Thank you, Dr. Davies. I know we're coming up close to time. Dr. Wiseman, I may just pivot to you. Certainly, if you have anything to say here, but if you also wanted to maybe give us a look, as we are in such uncertain times, so it's really hard to predict what's going to happen next week, let alone 24 months from now. But if you were to have kind of a guide for the audience of what's for the future here for Maimonides and what you're looking to do over the next 24 months, what would that look like for you?
Yeah, thanks. I mean, it's such a complicated question, and in New York also, there's a mayoral race coming up soon. There's a governor's race next year, and so there's all kinds of changes happening broadly. I think, we are trying to explore all the things that, as we said today, do right by the patients and do right by the clinicians and find ways to have the money follow. And so there's, the more partnerships, I think partnerships have been the key to what we've done so far. And so the more partnerships that we can create where we can help drive down length of stay, increase satisfaction, reduce readmissions, are what we need to be doing, and figuring out how to utilize our resources better. And I think, I talked briefly about both our own internal ambulance corps and our partnered ambulance, volunteer ambulance corps. I think those are key partnerships also where we can try to find ways to bring more care outside of the hospital and sort of reduce the need for people to come into the hospital or to find ways to get them out of the hospital faster.
Gotcha. Dr. Dale, you have anything there? And certainly feel free as we're coming in close to a landing. I think we got a couple questions we might be able to get to, but also any parting words you may have as you describe the next 24 months, what that looks like.
Well, it'll be interesting. Like for us, we're, like I mentioned this before, is like we're actively investigating transitioning to a non-waivered sort of program, thinking that allows greater operational freedoms. I mean, I think today is like a great case in point again with the continuing resolution not passing the House and Senate becoming a law and the government shutting down. It looking like it's going to shut down unless something happened in the last hour. Who knows? Maybe it's not. But that uncertainty just makes it hard to operate. And so what we're looking for is something sustainable. And then getting back actually to something that Matt said is our organization for a lot of times operated like tons of different types of services everywhere. And I think what we're thinking now in terms of just being more efficient and thinking through like how can we best serve our community is like we got to stay at doing the things that we're good at and then find really good partners that we can operate with to have them do the things that they're good at. And so it's not that we need to be everything to everybody in terms of operating home-based care delivery sorts of services, but if we can find a values aligned partner who believes the same things that we believe and is working towards the goals that we're working towards, we are very interested in partnering with those folks in the long term to provide really high value care to our patients. And so I think that's what the next 24 months look like is uncertainty probably on the waivered side, and then on the unwaivered side for us organizationally is trying to find good partners and good ways to operate to find better ways to deliver on our mission.
Excellent.
Hey, John,
Yes.
I've got a one-liner because I feel strongly in echoing a lot of the
Please.
sentiments of Matt and Chris. I would tell everybody who's here on this call, like, here we are talking about care at home as an alternative. I think what we have to understand is we got to frame shift with that. It is a necessity. And then I think what we're also seeing in our exercise of doing this is that once you put it out there, it becomes the expectation of our patients too. So we're moving from alternative to necessity to the
It's great. I'm scanning through the questions live. We've got some pretty good ones, from how more on the clinical operational side. There's some economic questions. Maybe I'll find this one. Social determinants is a big challenge, right? Complex health issues. Do you address patients with homelessness, substance use disorders, other aspects related to behavioral in these programs, ancillary programs? How do you think about that?
I could take that one. So
Sure.
right now where the program is at, no, we really don't go after those very intense social determinants of health. Now, we do take care of patients in a home-like setting, and that does include group homes and some of our medical shelters. So we do have a footprint there. But I will tell you just from an operator's lens of things, this is a program as we see it that needs to help those that are much more the inliers in terms of their social determinants than the outliers. There's a lot of depth to that answer. It's not to say that those patients aren't worthy of a resource. It's just a matter of resource kind of utilization and kind of getting that proverbial juice with each of the squeeze. I think the other thing that we're seeing, and most people can see this already, it's certainly where it's going. You know, hospitals are going to be the venue of high acuity medical and surgical care and high acuity social determinants in the future. And I think where we see resources like this working best is to focus on those patients that have medical and surgical conditions that are manageable at an alternative kind of venue of care near home in a stable home setting. So,
Great. Well, I know, Jamie, I'll turn it back to you. Really, want to thank the panel's time for your preparation for this, your perspectives, and a lot of the great nuggets you shared with the audience. And I want to thank the audience as well for sticking with us and joining. We know how busy everybody is. But Jamie, you wanted some parting thoughts and just some housekeeping items and what we'll do from here.
Yeah, thank you. So I know we have some questions that we didn't have time to get to, but we'll follow up post-webinar today. We also have a brief 2-minute survey following the webinar. So as soon as you log out, that'll pop up if you wouldn't mind filling that in for us. And then if you have any further questions, we're here too. So I know this was a lot to cover in a single hour, so happy to follow up after the event. And thank you all again so much. Enjoy your day.
Thank you.
Thanks, everyone.